Welcome to another hour of health education right here on WTVI. You've tuned into HealthWise, and I'm your host, Joey Pop. We're dedicating this hour to orthopedic concerns in children. It's one thing to set a youngster's broken bones or take care of sprains, but it's another to treat rare or severe pediatric orthopedic problems. We welcome to the set Dr. Virginia Casey.
It's great to be here.
Thank you, Dr. Casey. And her colleague, Dr. Christian Clark. Both are from OrthoCarolina, and they plan to discuss the diagnostics and procedures to help children with disorders large and small. Now, we also welcome your questions during the hour. In fact, you can send them to us now on our WTVI Facebook page, or you can email me directly here on set by going to jpop@wtvi.org. That's J-P as in Peter, O-P-P at WTVI.org. I can take the email right here and just pass it right along to the docs. Welcome.
Thank you.
Thank you.
This is your first time to be on the show, isn't it?
Yes.
Dr.
Yes.
Clark, is for you as well?
Absolutely.
Yeah, well, we thank you so much for being here. When I was researching the topic, I'm thinking, oh, isn't this really neat? We're going to get to do something for children. And then I started looking into exactly what this hour could be all about, and it could be very powerful for those parents and grandparents out there who have little youngsters with these concerns we're about to address. My heart goes out to you. But it's so nice to know that there's help and there's procedures that can be done, and that's exactly what these specialists are here today to discuss, to bring hope to young people. Is that a good way of phrasing it?
Absolutely. I think a lot of education as well. Some of the things that people perceive as being wrong are actually normal phases of growth that we help educate parents and cope with these issues as children outgrow them.
Oh, so are you saying perhaps as parents we're not patient enough?
I wouldn't say that you're not patient enough. I think that there are times during your life when you see certain things that can be very normal, and there are other times that it could be an abnormal finding, and it's up to us to kind of differentiate the two.
Oh, a nice liaison.
Yes.
And I guess a lot of what you do has to entail being supportive with the family,
Absolutely.
understanding their concerns.
Yes, absolutely.
So in addition to being an artist, you're also a counselor.
Well, we definitely have more than one patient in the room.
I bet. And that can be a challenge.
Well, and I think that all of us have children of our own, and so we've all had the experience that we understand that it's easy for us to say, no, that's normal, but it's very different for that person on the other side of the conversation to understand that, yes, we understand your concerns, we're going to validate them, but we can watch this and we expect certain things to get better.
All right. Let me just ask you a few generic questions before we get into your slides. And they've brought us some wonderful visuals for us to see and for them to explore and educate us what's being done for these conditions. But what's the most common thing you see? Dr. Casey, you first.
I think the most common thing I see has to do with hip problems. And it can be hip dysplasia, which is a failure for the hip joint to develop well. Or it can be an injury that occurs during childhood, or it can be a problem that develops over chronic use, not necessarily an acute injury. So I would say not most, but 50% of my practice has to do with hips in children.
All right. So in your specialty, you're a surgeon.
Yes, I am. So lots
and
of
hip is one of the main concentrations, you're saying.
Exactly. So I see children with all problems, and I operate on all parts of the body in the musculoskeletal system in children, but I do focus on hip disorders.
How about for you, Dr. Clark?
We see a fair number of both acute injuries and overuse injuries. Obviously, there's a large group of kids who are very involved in sports, and so we get to see them both for kind of normal findings that we expect during growth and also some kind of acute injuries.
So when you say acute, you mean short term?
Short term. Somebody is out playing basketball and has an injury to their shoulder or knee, then those are the people that I often see.
All right. Let's go ahead and go to the first slide if we can, and let's go right into this topic. You're in for a good hour here on HealthWise. All right. We have seen bow leg in people walking down the street, and you're just like, oh, can't something be done for someone with this condition? Explain what bow leg is. Dr. Casey, are you first?
Sure. So bow leg is when the feet are together, and then you can see that there's space between the knees. And another term for that is called Genu Varum, and it just means the knees are shaped outwardly. And in children, this actually can be normal at certain stages and then is no longer normal at others. So when you have a brand newborn baby, they're frequently bow-legged, and that's okay. But as the child matures, by about age 2 to 2.5, their legs should be straight. And then they can go, and we'll show you on the next slide, but they should not be bow-legged past about 2.5 years old, or it means that there's something else going on that needs treatment.
Before we go to the next slide, Dr. Clark, did you want to add anything with this?
There are several things. Dr. Casey kind of implied it. There are certain medical issues, things like rickets. There are other issues, something called Blount's, that we definitely look for in these children. And this is exactly what I was referring to when I said that we understand your concerns. You look at your child and you say that that's not what my neighbor's child looks like, and they're the same age. And so we don't want to dismiss it, but at certain times of your life, this can be very normal. And if we say that we'll watch it, we don't want you to feel like we don't understand your concern.
My parents are watching this show right now, and they looked at that first slide, and they're saying to themselves, that's what Joey's legs looked like when he was a kid. And I'll look at my baby pictures, and it's amazing to me that my legs were bowed like this. But as you said, Dr. Casey, thank goodness within a year or two, they did straighten back up. So, and why was that the case?
Well, you must have had what we call physiologic bowing, which means a normal phase of growth bowing. And we say normal, but that doesn't mean everybody goes through that phase. But it can be normal. And so your growth plates responded when you were young to grow a little bit crooked and then straighten out on their own. So physiologic Genu Varum.
Wow, that's amazing. That really is amazing. Okay, let's go to the next slide, and let's just see what can be done if, in fact, Mother Nature doesn't cooperate. Or knock knees, is that just the total opposite?
That's another phase in the normal growth. And so as strange as it seems, that young child will actually go from being bow-legged to a straight leg, and you think that you're out of the woods and everything is going to be fine, and then all of a sudden you look at their knees and now they're knock-kneed, or what we call Genu Valgum. So that's another phase that people often go through, and my son Grant actually has a significant amount of it right now. But that's something that's normal. He will grow out of that. We can continue to watch that.
Is there something that can be done outside a medical procedure? For instance, do you advise the parents, why don't you get him involved in some type of sport activity or dance school? Does that help with the leg?
It doesn't.
It does not.
It doesn't. In fact, we used to brace all sorts of children for these kinds of conditions. And we thought that by bracing them, they were getting better. And we've learned, however, that they get better whether we brace them or not. So we don't have to use Forrest Gump braces and subject these children to these things most of the time.
How about that? So is it good to exercise when the legs are in this condition?
It doesn't make too much of a difference. I mean, it's the type of thing that this is, again, what we consider a normal phase. And what we often will tell you is that for knock knees, we'll have you put the knees together and measure the distance in between the ankles, and that should gradually improve. And as long as it improves, then we get to watch it. If it doesn't improve, then there are some small surgeries that we can do in the future to actually correct that.
All right. So once again, patience.
Patience.
Is the virtue here. Okay. So let's go to the next slide, and it kind of shows a different type of concern, pigeon-toed, right?
Yes. This is one of the things that we often see. There are actually, the picture in the middle actually shows a young girl walking down the hall with a very slight but a noticeable in-toeing gait, where her toes are actually pointed inward towards each other. One of the most common reasons for this is femoral anteversion, which is just an extra bit of rotation in the hips. This is, again, something that we can watch. I think that this often confuses people because this is something that we might have braced a generation or two ago, but it's something that we absolutely watch today.
And we've seen young people sit like that.
Absolutely, and I often tell parents that my first grade teacher would tell kids not to sit in the W position, but what I tell them now is that it doesn't make a difference.
Really?
That the anatomy is letting them sit in the W position. It's not that sitting in the W position is going to change their anatomy.
And looking at that, it does appear to be so painful.
And that's the whole point, is that that child isn't in discomfort at all. That's the comfortable position. It would probably be more uncomfortable for them to try to sit cross-legged, just as if somebody tried to make me sit in that W position, it would be uncomfortable for me. So wherever they feel comfortable, that's where they should be.
Amazing. All right, let's go to the next slide. And Dr. Casey, I'm going to let you take it away here, since your specialty is hip.
Yeah, this slide just shows a picture of a Pavlik harness, and the reason we put this in was just to show people one of the treatments for hip dysplasia. And this is the hip dysplasia that you notice early on in development. And if you recall, your pediatrician is taking your baby's hips, and every single visit they're checking their hips. That's something that's part of the newborn exam, and it's something they do every single time. And they do that to see if the hips are loose at all. And if the hips are loose, or they feel a click or a clunk, then they're going to refer you to see one of us. And if we find the same thing, then your child will likely be treated in this type of harness.
And how long will the child have to be in that harness?
It is variable. If they have a good response from it, then it'll be about 6 weeks to 3 months in the harness.
And that young person has to live that way 24/7?
You know, they don't notice one bit. They're between newborn and 6 months old typically, and the babies tolerate it beautifully. It's definitely an adjustment period for the parents, and my heart goes out to the parents that have to change diapers and around this harness, and frequently these are first-time parents because hip dysplasia is more common in your first baby.
Wow. And then you get the public that will stare, probably.
Right.
And that's where it can be very challenging, I would think, for a parent, if not a grandparent.
Absolutely.
Yeah. All right, let's go to the next slide. And it shows a skeleton concern here. What are we looking at?
Well, this is just an example of the difference between a pediatric skeleton and an adult skeleton. One of the issues that we often see with trauma is that someone will come in with an injury, such as to their elbow. And what I really wanted to show on this slide is that you'll see that in the pediatric elbow, there almost seems to be large pieces of it missing.
Yeah.
And that's because it's still a growing elbow. It's still a growing skeleton. And the area where the skeleton grows is actually made of cartilage, so it doesn't show up on X-ray. So often we'll actually need to rely more on an exam than actually looking at the radiograph and saying, yes, this is the fracture. You can see it here. The right side is the adult elbow. If you were to look at these outside of the skin, kind of stripping away the skin and muscle, they would look the exact same.
Is that right? Now, will the youngster's arm heal quicker and better than the adult?
Absolutely. One of the nice things is that children have an incredible remodeling ability. Often the fractures that we see in young children are more bends in the bone than actual true fractures. I often describe a child's bone more like plastic and an adult's more like glass, that if you try to bend it, it breaks into pieces.
Okay, how many arms have you had to set this winter with this sleigh season of ours?
Far too many.
And that's something else I did as a youngster, was break my arm sleigh riding. So I would think that that is something that you've been busy with here lately.
Absolutely. We are more busy in the summertime. Daylight savings time really marks the beginning of our busy season because the kids are outside, and we certainly encourage kids to be out and active, but they do injure themselves more.
All right, we have some calls already coming in. So let's go ahead and take a little break from our slideshow, and let's take a call. You want to?
Absolutely.
James is calling from Charlotte here. Hi, James. Welcome to the show.
Well, good evening. A wonderful show. I watch you folks all the time.
Well, thanks, James.
Patellofemoral Syndrome. It's does that begin at early childhood? I see adults that they walk like their toes are pointing out, like they're going through a row of corn. Are you with me on that? Is there such a thing as piriformis muscle?
Let's hear what they
piriformis
have.
syndrome.
Let's hear what they have to say. Thanks for the question. Who wants to take it, Dr. Clark?
Absolutely, there's a piriformis. I mean, that's a muscle in the gluteal region. I don't normally associate that with younger children. Definitely, as you get a little bit older into your teenage years or your adult years, you can start to have some irritation. Usually that irritation is of the sciatic nerve, but I don't specifically think of it as a pediatric issue.
James, you have a follow-up?
No, thank you. I was really interested in knowing whether or not that did occur with young people, because I now have 6 great-grandchildren, so we kind of watch out for them as well. Thank you, sir.
Great. Thank you so much, and thanks for tuning into the show each week. We appreciate that. Before we take any more callers, let's go back to our slides. This is a fracture healing slide, and what are we looking at here? Is that a pin in the far left?
It is a pin, and you can certainly treat fractures in children with pins. You don't always need to, and this particular fracture probably would have healed fine without the pin, but the whole point of this x-ray really is to show the amazing potential for the child to make their bone straight.
And we're looking at an arm here, right? A wrist?
Yes, this is a wrist, and it's a radius fracture. If you see how displaced it is on that x-ray that's to the left.
Yes.
And then through the healing process, the body, if you look at the one in the middle, the body is bridging in the area that would make the bone straight. And over just 4 months time period, and sometimes this can take longer, in this particular patient it happened quite quickly, the body added bone where it needed to make it straight and took away bone in order to make the anatomy normal again. Amazing.
So why isn't there a pin in the second slide here?
Well, there was enough healing that the pin could be removed in order to let the child heal without risk of infection.
Because it looks very similar to the slide to the left.
Right.
But just enough is there that it will gradually move over and heal on its own.
Do you see that triangle of whiteness between the where the pin used to be, between the 2 edges of bones? There's a triangle there.
And the slide in the middle.
In the slide in the middle. And that triangle is bridging bone.
I see. Okay.
And when you see that bridging bone that's connecting the 2 bones, even though it doesn't, you can still see the fracture.
Right.
That's enough bone to feel good that the fracture's not going to move and the pin doesn't need to be there anymore.
Amazing. And then on the far right, that's complete healing?
It's complete healing, and an adult could not do this. So this is really here to show what children can do. One of the common things we say in medicine is children are not just little adults. And this is points to that.
Wow, that's amazing. So when will they outgrow having this capability of having this healing done quickly and precisely?
Well, it's a gradual process. And actually, when they're newborns, if a newborn baby breaks their femur, so the big thigh bone, we frequently say as long as it's in the same room, the 2 bone ends are in the same room, it's going to do fine. But as they get older and older, we have limits on what we can accept. So we can accept certain alignment when they're really young that you can't accept when they're, 10. And you can accept a certain alignment when they're 10 that you can't accept when they're 16. So we know, kind of based on location, type of fracture, and age, how much intervention is necessary and how little, so that we don't operate or, cut skin on things we don't need to, but that we do when we do need to.
And I can perfectly relate with what you're talking about. I have a nephew who I think broke his arm, if not his leg, when he was like 2. And it was like, oh my gosh, you're kidding me. He broke a bone at age 2. The kid's 8 now, and he's the biggest athlete. You would never know he had an injury like that.
Yep, kids have an amazing potential to heal. We just have to guide them.
Have to guide them. All right. Let's go to the next slide. Growth plate injuries. I believe, Dr. Clark, this is your specialty?
Well, I would say that all of us deal with this. This is one of the more common things that we see. So the nice thing about young people when they have a fracture is that they do have that incredible ability to remodel. The downside is that they do have growth areas of their bone, and we have to get concerned about some of them. Occasionally, you'll have an injury through the growth plate and it doesn't cause any true problem to the area that's actively growing. And those are things that we can often just watch and treat for a short period of time. There are other types of fractures, especially when the fracture goes into the joint, that we have to worry a little bit more about it. And there are certain locations like the end of the thigh bone, the ankle, that are specific that we have to really watch those closely. And occasionally, it'll shut down that growth plate prematurely, and there will be a future problem with the amount of growth, the direction of growth, and occasionally we have to intervene at that point.
All right, great. And I appreciate you showing us the good side of this and what could be a side effect of this as well. We've had a question just come in, and the question is, could a child develop being bow-legged if they should walk too early in life?
We do frequently see bow-leggedness early in life being associated with early walkers, but it doesn't make it necessarily a worse condition. It still typically tends to go away by about age 2 to 2.5.
Okay. Because, you know, parents, they can be very like, oh, let's watch little Johnny walk here, and so just don't go too early, huh, Dr. Clark?
I don't think that you have to push them down and prevent them from walking, but we do occasionally see that the early walkers, and it might just be that the parents are watching them more closely, that there is that bowing. But it doesn't necessarily mean that it's an issue.
Good to know, and I'm glad you addressed that. Your specialty is hip. Your specialty, did we talk about that? You help with young people with ACL concerns and sport injuries?
That's a portion of my practice. Yeah. The same way that the adults are out there playing football and basketball and have injuries to their knees, we also see it in young kids. It's a little bit of a different situation the younger you are. We previously used to think that young kids didn't get ACL tears. And the thought was that they actually tore off a piece of the bone, and there's actually a slide of the ACL injury.
Yeah, let's go ahead and go right to that one. The ACL injury, which I think is going to be slide like number 15, maybe 13. There we go.
So the left side is what we classically think of the adult or mature injury, where the injury is actually through the tendon, or sorry, the ligament itself. And what we previously thought is that young kids would actually peel off the piece of bone that the ACL was actually attaching to on the top of the shin bone. We know that that's not necessarily true anymore, that there are true cases of ACL injuries in young children, but often we have to watch for that tibial spine kind of pulling off. Sorry?
No, I was just going to say, both of you are with OrthoCarolina, and you practice at your main facility on Randolph, but you also branch off, and you work at the Ballantyne office?
Ballantyne and Pineville.
And Pineville.
Correct.
And then you're up in Huntersville.
Yes.
Okay, so you're kind of like across the region here, across the county at least. Feel free to phone in your questions here. We're about to take our break, 704-371-8895. And once again, you can email me at jpop@wtvi.org. I know you want to get your questions in, and when we come back from the break, we only have 20 minutes. So you may want to go ahead and start dialing now. Let's go to one more slide before we take the break, and let's see what we're discussing here. We'll go back to our chronological order. What is this?
Apophysitis is a fancy name for a condition where a tendon inserts on a piece of bone that is growing. And so these are two of the more common types that we actually see in young children. The one on the left is Sever's disease. It's a condition that I see an incredible amount of time in young kids who are playing sports with cleats. And I think that that's likely related to the fact that they don't have good cushioning in cleats. And so as these kids are running around pounding on their heels in these very hard sole shoes, they come in and start complaining of heel discomfort. The nice thing is that it does go away by itself. The bad thing is that it doesn't go away until that area closes. And that can be in their teenage years. So often we have to give them a little heel cup, a little cushion, and that will make them significantly better.
And this is something they will wear with their dress shoe, their tennis shoes?
They can take it from shoe to shoe. It's something relatively small. It doesn't cause too much of a problem with shoe wear.
Is this something that an adult can also experience?
They have a similar type of situation. Often we think of the plantar fascia as a source of discomfort, or the Achilles tendon as a source of discomfort in adults. This area of the heel is actually closed off by the time you're an adult, so it doesn't tend to cause a problem.
Interesting.
One other thing I talk to parents about is it is a growth plate, and our bones have growth plates, but our tendons and our muscles and our ligaments don't. So kids need to be stretching as well to help keep their joints loose so they don't put extra strain on these growth plates. And the ankle is certainly an area where kind of those kids between ages 8 and 11 typically experience that Seaver's disease, that heel problem, that stretching in addition to the heel cups can help them quite significantly.
Instead of just going right out there and hitting the court or the field.
Exactly.
Be sure and stretch. Because stretching is so important the older we get.
Absolutely.
You know, I guess it's just a gimme that the kids are young enough and they can go out and just start cold, but that's not the case.
It's not, and I think it's a common misconception that kids don't need to stretch. You need to warm your body up first for 5 or 10 minutes to get the blood flowing, get your muscles warm, and then stretch, and then participate in your activity. Good
to know. Remember that, parents and grandparents. Let's go to one more slide here. What is this, a syndrome?
This is just one of the more common issues that I see in the clinic. Patellofemoral Syndrome is just a fancy name for an irritation between the end of the thigh bone and the kneecap. It can be caused by a number of reasons. There was one of the Apophysitises is actually related to this. Osgood-Schlatter's and Sinding-Larsen is an irritation at the tops of the patellar tendon and bottom of the patellar tendon. And then you have immature muscles starting to become stronger. And so it can start to pull on that kneecap in such a fashion that it starts to rub on the end of the thigh bone and cause some discomfort. If you start to have some of that Genu Valgum that I was talking about previously, that can also put a little bit of strain on the backside of the kneecap. Often we can treat this with just a little bit of physical therapy and anti-inflammatory, something like Motrin or Naprosyn, and it seems to get better.
And that has to be a relief to the parents who bring their loved ones in thinking, oh gosh, we're taking them to a specialist. That means they're going to be under the knife. Is that the biggest fear?
And it's quite unfounded in the sense that we see a large number of kids and very few of them need surgery. Often it's something that we can kind of educate the patient and the parent, treat them with some medication or physical therapy, and they'll feel significantly better.
And I think another big fear of parents is that because they're having problems now at such a young age that they're destined to have problems as an adult. Mm-hmm. And that's just not necessarily true. A lot of these problems are just growth related or activity related. It doesn't mean that they're going to have, not going to need a knee replacement when they're, in their 50s for sure, just because they're having these issues when they're kids.
And you kind of wrapped that little summary up at the very beginning of this show. So it really does set the whole tone that what we're looking at, don't look at it as being a chronic, if not an introduction to a problem, not too far down their adult life.
Sure, exactly. There are some issues, some things we see in childhood that we worry are going to cause problems as adults, but those are few and far between, and we do address those frequently surgically. But a lot of these things that we're talking about today, the overuse issues and kind of the angular, not deformities, but normal development of the legs, aren't going to cause problems.
Let's try to get Ann in from Indian Trail before we take our break. Hi, Ann. Welcome to the show.
Hi. How are you all?
How are you?
I'm doing good.
What's your question?
Well, I have two children, ages 10 and 5, and they both have extremely flat feet. So much so that my son, he plays sports, and I don't know if it's causing him any big discomfort, but it kind of bothers his knees at times. And aside from orthotics, which is what he's been fitted for, is there anything else that can be done to help aid in that issue?
And did you say it concerns it affects his knees, or it affects you? Did you say knees?
I think it does affect me. And then for him, though, I mean, now that he's started to play sports, I think sometimes he says that his knees kind of bother him.
Gotcha, his
we're
knees.
Just wondering if that is the cause of it. By
Sure.
his feet being so flat, he runs really with these long strides. You know, he won't run on the balls of his toes.
Right, right. And that has you concerned as a parent. Let's hear what the specialists have to say to that. Who wants to take it?
I would say that I see that situation a fair amount too. The first thing I would say is that flat feet aren't abnormal. I consider them a variant of normal. It doesn't have to be something that you have to take care of. There are a lot of people who have flat feet and don't have any issues with them. I would say if your son has some discomfort in his knees, it may be because of the flat feet, but it might also be something completely different. I think that you're doing the exact right thing by using orthotics. I would say that there are some shoe modifications that you can do. Most of the large shoe companies actually make shoes specifically for somebody who has a bit of a flat foot. And that can often take some of the stress off of the lower extremity. One of the things that we often look for is it a flexible flat foot? Does his foot come into a nice arch position when he's off of it or when he goes up on his toes? So it doesn't have to be a problem, but it's something that we can definitely kind of evaluate and see if there's anything that we need to do for it.
And a nice easy test for you to find out if the feet are flexible or not is to look at him from behind and have look at his heels and then have him go up way high on his toes. And if he can make an arch in his foot, then it's likely that that's a flexible flat foot and not a problematic flat foot.
And good to know, and I hope that helps.
It does. Thank you very much.
We thank you for tuning in. When we come back from the break, more concerns and treatments. You're enjoying HealthWise on WTVI.
HealthWise is brought to you by OrthoCarolina, a comprehensive orthopedic practice with locations throughout the Charlotte region. OrthoCarolina, excellence in orthopedics, on the web at OrthoCarolina.com. And by the Mecklenburg County Health Department, and by viewers like you. Thank you. If you would like support group information about tonight's topic or any HealthWise topic, call SupportWorks at 704-331-9500.
And we're discussing pediatric orthopedics. Doctors Virginia Casey and Christian Clark are here from OrthoCarolina, and we thank you so much for tuning in. You're welcome to join the conversation by calling 704-371-8895 or email me, jpop@wtvi.org, and we will certainly take your question here on set. Now, you brought a hip.
I brought a pelvis.
Is that real, by the way?
No.
No.
This is called a sawbones pelvis, and actually when we teach residents how to do surgeries, we frequently start on something like this. And I brought this just to show, so we could talk about hip dysplasia a little bit and help people understand what hip dysplasia is. If you can see, I don't know if you can appreciate this circle here.
Go ahead and rotate it around to this camera right here. There we go. There we go.
So there we are from the front, and I'll look at this is where the ball of the thigh bone sits. So this is half the hip joint, and I didn't bring the other half because I wanted you to be able to see this part, because this is the part that is involved in hip dysplasia. You can see that it's nice and deep, that there's a place inside, and with hip dysplasia, this is very flat, and this edge here is frequently angled upward. And this is a problem that not only do we see in young children, newborns, but it's something that we can see in kids as they mature. So if it's not, it's called developmental hip dysplasia because it can't necessarily detect it in all newborns. So it's possible to have symptoms at age 16, 17 years old, get an x-ray and find out you have shallow hip joint, and it's hip dysplasia, but it's not necessarily the same hip dysplasia that newborns have, where their hip is actually sitting dislocated. It's out here instead of in the joint.
And what can be done in that regard? The braces?
Well, unfortunately, we can brace the little kids when they're newborns, but once you're a teenager and you've got a developed pelvis, bracing doesn't work, and it's a surgical procedure. And it's a fairly extensive one, actually. There are lines on this pelvis to show you where you cut. and you cut all the way around it and angle it so that you can make it a deeper socket, hopefully to allow them to have a hip joint to last for the rest of their lives.
And what can be done, what advice can you give to a parent or a grandparent out there to make sure that it's not diagnosed in their teen years, or is there something?
Well, unfortunately, this isn't a condition that really has symptoms until it's kind of too late, except for the newborn period. So regular newborn visits, the pediatricians can feel that, and then the separate kind of hip dysplasia, the kind that doesn't show up as newborns, really you just have to get an x-ray when they're older. And if the child is complaining of groin pain or pain around the hip, it's probably worth getting an x-ray just to make sure that you're not missing a disorder around the hip, because there are some disorders around the hip that can be fixed with just a single screw, and it's very important to not let it get too far so that it has to be fixed with a big surgery like this and can only be fixed with a small surgery.
Good to know, Dr. Casey. Let's go over to Gastonia. We have Shelley with us now. Hi, Shelley. Sherry, I'm sorry. Sherry, are you with us? Sherry from Gastonia. Are you with us? Hi, what's your question?
I have a now 15-year-old that has broken both ankles twice. We have dealt with several sprains 3 or 4 times a year. All the breaks have been along usually the growth plate area. We found out the growth plates are fused, but she keeps having continual pain, swelling, sprains. Is there anything maybe we're missing, or is there another syndrome maybe she could have that no one's picked up on?
All right, let's hear what they have to say. Dr. Clark?
One of the things that I would say is the injuries at the growth plate in the ankle, it's one of those diagnoses that we often make, and we make it with the presumption that it's a young person with open growth plates on their radiographs, and they have discomfort over the area. I tried to tell people that though we call them a fracture because they're an injury to the skeleton, that's not the same as having a fracture to the middle aspect of the forearm. It's a little bit difficult to kind of guess what's happening with your daughter in the sense that it would be nice to have an exam because my question is there a significant amount of instability? Occasionally, as people have a repetitive injury to the outer aspect of their ankle, they actually stretch out those ligaments, and what needs to happen is that you need to kind of shorten them or give some additional support to those ligaments, and that will take away most of the symptoms. The other question that would be there is there any injury inside the ankle to the actual joint itself?
Enough of a concern. Is she under care right now, Sherry?
Yes, and it's kind of been brushed off. You know, she's klutzy, and she's a big girl. She is 5'10", and they just kind of put it off as she'll be okay. But I'm quite concerned because it just does not seem normal.
Right, and as we say just about every week on this show, you know, it doesn't hurt to get a second opinion.
Has she gone through physical therapy?
We've done physical therapy.
Okay.
And this is stopping her from a lot of activities she would enjoy doing.
Yeah, so it's affecting quality of life, it sounds like.
Yes, sir.
All right, well, once again, maybe a second opinion is something that would be advice to a parent? All right. Sherry, we thank you so much for the call, and I'm sure you represent many parents out there who have issues at home with loved ones, and they're thinking, you know, I just don't want to upset my doctor that I've been going to. What is your advice when it comes to getting a second opinion? Because people are concerned about hurting feelings.
I think that you shouldn't worry about hurting feelings. I think that this is a very personal issue to each person, that I would not take it personally if somebody saw a partner of mine or somebody down the street. I think that what I like to do as a physician is give you options, and if none of those options seem to be something that you would like to choose, then absolutely search out more options. And then if you hear those same options from every person that you see, then you can feel more secure that those are really the options that you have to choose from.
And you're doing what you can.
Absolutely.
At least it takes that guesswork out of you and perhaps feeling guilty about not exploring other possibilities for your child. Sherry, we thank you so much. Let's go back to the slides. Little leaguer's elbow. This is interesting, and this is something we've heard about for a long time.
This is a situation that ends up getting an incredible amount of press, mainly because of the number of kids who have symptoms from it, the fact that it is something that is preventable, and then Dr. Andrews from Alabama has done a great job of creating restrictions on young pitchers or young baseball players to try to help prevent this. It's a very simple thing to prevent, but it can lead to more significant issues.
All right, next slide. And it will be coming up here in just a second.
And this is one of those issues that it can lead to. So originally, Little Leaguer's elbow is some discomfort along the inner aspect of the elbow. Occasionally, you can actually pull off the growth plate, the piece of bone that's attached to the growth plate, or overload the outer aspect of the elbow. And when you start to overload the outer aspect of the elbow, the two pieces of bone are almost pounding into each other, and you can end up with something called Osteochondritis Dissecans. We often shorten it to just OCD.
Yeah, which is bone on bone.
Well, it's not necessarily arthritis. So the way that I think of this is that cartilage is a Teflon coating at the end of the bone in the joint. Okay. And what's happening with an OCD lesion is the bone underneath the cartilage has been injured. And if time goes on and there's no treatment, then the cartilage can actually be injured, and you can actually have a piece of that bone cartilage become dislodged.
And I believe the next slide actually shows treatment. So let's go ahead and bring that up before we go to our next caller.
So often as surgeons, we often talk about the surgical treatments, and these are some examples of surgical treatments, but often we can treat these, especially the most common place for an OCD lesion is in the knee at the end of the thigh bone. We don't know why these are caused. They can be associated with some repetitive microtrauma. It can be familial, but often the treatment early is just taking the child out of sports and decreasing their activities.
What are we looking at in the far left?
So if that doesn't seem to respond, or that piece has already started to come loose, then what you can actually do is take the child to the operating room, have them take a short nap, make some small incisions, put a small camera inside the knee, and you can actually take a wire and you can poke across the cartilage into almost the marrow space. I like to think that there's some precursor cells in that marrow space that will leak into the area and actually allow it to heal. We're much better at taking care of these when the children are still in their growing phases of life. So this is something that we like to take care of early if we can.
What's early, once again?
While they're still growing, while their growth plates are still open.
Have we established what age we're talking about? Before puberty, I would think.
Well,
or is
not
it
necessarily.
Before age 20.
So all of the bones tend to close at different times of development. So it's not, you can say, at 12, it will be closed. And then there's also a range for females and males. So
right.
Unfortunately, we can't say this age. But you can look at an X-ray and say, is the growth still occurring?
Very good. Let's go over to Concord with Jody. Hi, Jody. Welcome to the show.
Hi.
What's your question?
My daughter is almost 2.5 years old, and a little over a year and a half ago, she was diagnosed with familial spastic paraparesis, and she has been undergoing physical therapy for about 10 months now, and the doctor or the physical therapist is recommending possibly some orthotics, and so we're going to meet with the orthopedic doctor here soon. So I was just wondering what possibly they would want to do to her.
Okay. And before you answer the question, will you explain to the viewer what we're talking about here?
Well, basically, we found out that she has a genetic disorder. My husband has it, and his mother has it, and she has poor balance, and her legs seem kind of tight. From what I understood the neurologist saying is the nerves in her legs causes her muscles to spasm, and they kind of draw up real tight. and so she kind of walks. She never really walks the same, but I know my husband walks a lot, like on his tippy toes.
Right, right.
And she like I said, she's almost 2.5, and she doesn't kind of like bend her knees a lot. She can't go up steps yet.
Okay,
so,
let's hear what they have to say, and I thank you so much for this question. Thank you, Jody. Dr. Casey?
Yes. Well, it sounds like the orthopedic needs of your daughter are going to be kind of twofold. And what we tend to do for kids that have this spasticity, where they can't control what their muscles are doing, is we try to balance the muscles and keep it so that she doesn't end up with contractures, so that her knees don't get stuck bent or her ankles don't get stuck pushed down. Typically, it's a combination of treatments with physical therapy and bracing and sometimes Botox injections into the muscles, and also sometimes surgery to lengthen the tendons of the muscles that are too tight to balance her muscles to help her walk with a more normal gait and get around.
So there's hope for this young person.
Absolutely.
Okay, and Jody, we appreciate the call, and remember that with the treatment that she's about to go through. Sandra from Charlotte, welcome to the show.
Hello.
Hi.
I am a grandmother.
Thank you for calling.
Thank you. I'm a grandmother of a 6-month-old. It seems like his Achilles tendons is so tight that his toes are pointing down. And when I checked his plantar reflex, he's not able to put his foot flat. He just stays on his toes, and I'm concerned.
Okay, and you said he's 6 months old now?
Yeah.
All right, so he hasn't really stood up yet. He hasn't put any weight on his feet, correct?
No, but if you try to put him, he just goes right on top of his toes.
I understand. Let's hear what they have to say, and I think it's a great question.
Thank you.
Dr. Clark, Dr. Casey wants to take it.
I'll take that one.
Okay, Dr. Casey.
What I'd be interested to know is if you move his foot, not when you're trying to stand him up, but if you just try to move his foot, can he get his foot up?
No, it just stays pointed down.
It stays pointed down, so no matter what you do, you can never put it in a normal position.
No, because I've been trying to do a little bit of exercise with it, and it goes right back. It's so tight at the back.
Yes, well, that sounds like a young man we need to see.
Okay.
That may be a good signal, a red flag, for you to get your grandson into a specialist. And we thank you so much for the call, Sandra. And thanks for being that great grandparent for noticing this too, right? Because I would think that parents are just so consumed with their child that perhaps they don't notice something that grandma or grandpa may notice. Is this true?
It's some people notice some things and some notice others. So it's hard to comment on that one. I don't want to upset parents.
Sure, I know.
Well, we often joke that kids don't come with handbooks. So it's the type of thing that the grandparent has already been through it once, and they can at least relate to when the parent was a child. And, well, this is different from when you were a child. We should probably have somebody look at it.
Good to know. And speaking on that term, what is new in your field today that perhaps wasn't around when the grandparents were around, or maybe as recent as 5 years ago? Is your field ever changing?
It's changing in an incredible amount. And one of the things that I think about is the decrease in the amount of bracing that we do and the amount that we can change the position of joints with guided growth. That we can do relatively small surgeries to help correct a deformity that we see. So if a bone is a little bit bent in a position that we don't necessarily like, then we can try to help that child grow into a more normal position.
Without pain?
With minimal surgery and minimizing that discomfort that they're going to have. That's a little bit different than what we did in the past, where we started to cut bones and put them in that better position. This is a more, let's guide it to that position over time.
We take advantage of the growth and tether it on one side and allow the other side to grow. So right after the operation, the children aren't any straighter, but over the next 6 months to a year, they actually grow themselves straighter.
Charlotte, let's come back to the Queen City. We have Peggy with us now. Hi, Peggy.
Hi.
What's your question?
My 6-month-old grandson has a toe that sits on top of the other toes. Is there something we can do now to correct that problem?
I saw them look at one another. Is this something you hear often?
We do. We see it a fair amount. Often what this is actually what we call a curly toe, and it's not the toe that's sitting on top that actually causes the issue. It's actually the toe that curls underneath. Occasionally what will happen in young children is that the tendon on the bottom, the flexor tendon that helps bend the toe, just gets too tight, and it wants to sit in that flex position, and it forces the upper toe towards the top of the shoe. Often if we just cut the tendon for the flexor, it'll swing back into its more normal position and allow that toe that's being pushed up to kind of settle back down in its neutral position.
Frequently we don't have to do anything though, and usually we avoid anything until the children are about age 3. So your 6-month-old would get a let's watch and see what happens over time kind of response at first.
And there are little braces that we can use for that, little attachments, and sometimes just buddy taping will help.
Peggy, does that help? Yes, I think it does. We thank you so much for phoning that in. We have a couple more slides to go through as our time is escaping, so let's go to the next one. Who wants to take this one?
I can take this. There are several situations in young kids where we can have a little bit of a variant in their normal development, and this is an example of it. The outer meniscus, which is one of the shock absorbers in the knee, can actually have a little bit too much tissue there, and it's what we call a discoid meniscus. And if you look on the left bottom, on the far left of that picture, you actually see a normal-looking meniscus, which looks like a crescent moon, and then as you go to the right, it looks more like a full moon. Occasionally, young kids will actually come in with discomfort, mechanical symptoms, clicking, locking of their knee, and we look at the x-ray or look at an MRI, and we can actually see this extra bit of meniscus.
And then the next slide.
And young kids are no different than adults in the sense that they can have meniscal tears. The two basic types of meniscal tears, one is what we consider a radial tear. That's the top picture, the torn flap. If that's a small piece, then often what we'll do is actually just trim that out. Menisci are very important. They're protective of the cartilage, so we don't want to take out too much. So if it is repairable, like the bottom picture, the bucket handle tear, then we'll actually fix it. And kids are much better at healing those than adults, so it's something that we like to try to fix it if we can.
This is something we addressed earlier in the show, that with these concerns that we've seen, young people are getting the help. Can they live normal lives? Dr. Casey?
Most of the time, yes. The vast majority of the things that we see as pediatric orthopedics, either they fix themselves or we can fix them, and kids can live normal, healthy lives. There are some conditions that certainly do provide some limitations for kids as they become adults. And we address those and do the best we can, but I'm hopeful with research and more work, we'll get better and better and be able to give more care to these children.
Dr. Clark, I would think it takes a special person to go into this specialty. What drove you to it?
I've always had an interest in it. From the time that I had an interest in orthopedics, I had an interest in pediatric orthopedics, and I think it has a lot to do with your mentors. You find somebody who you really can admire and appreciate for what they do, and you want to follow in their footsteps.
And who was your mentor?
It was several people at Georgetown University.
Are you from D.C.?
I went to medical school there in residency.
And how long have you been in Charlotte?
2 years now.
Well, welcome.
Thank you.
Dr. Casey, how about yourself? Where are you from?
Oh, gosh, that's a hard question.
You grew up in many places like me, I bet.
Yes, Winston-Salem and Oklahoma City. And then my training was in Oklahoma and Utah and Dallas.
Wow, been around. Well,
yes.
we both lived in the Twin Cities. I was there as well as a youngster. In fact, that's where I broke my arm. Got it set at Baptist Hospital. This has been a fascinating hour, and we thank you so much for being here, Dr. Virginia Casey, Dr. Christian Clark, both from OrthoCarolina right here in Charlotte with offices throughout Mecklenburg County. We thank you for being here.
Thank you.
Come back,
Absolutely.
okay? As always, we hope that this medical broadcast has helped you become more health-wise. Now, if you didn't have a chance to get your question in, you can email me through the week at jpop@wtvi.org. I will forward your email right to these doctors, and the doctors we've had on the shows previously, they're really good about responding. So it's all about communication, and we thank you for being a part of this mission because that's the reason we're here. Make it a great week, and once again, thanks for tuning in. I'm Joey Pop.
If you would like support group information about tonight's topic or any HealthWise topic, call SupportWorks at 704-331-9500. If you have a comment or question about HealthWise, call 704-371-8836 or email us at healthwise@wtvi.org or go to the website wtvi.org. If you are interested in being a guest on HealthWise or like to sponsor a HealthWise program, please call Suzanne Milkey at 704-372-2442. Learn more about HealthWise and other local productions at WTVI.org. Go to our website and you will see current and upcoming events on air and in the community. That and much more at WTVI.org.